All right, looks like we are live and we're here. And thank you very much. I'm very grateful for these amazing folks that have joined us today. And we're just gonna, I guess, dive right into it because we want to be able to cover a lot of area. And so I think we should just do some introductions as we go. My name is Bruce Riley. I'm the Deputy Director of Voice of the Experienced. And we're here to talk about medical care in Louisiana, in the prisons. And so we have 3 bills at the legislature this year that we want to touch on. But first I'd like to call up one of my colleagues, Anthony Hingle, who's going to share with us just a little bit about how one gets medical care inside the prisons and a little bit of his story about what happened when he had to put in a slip, as we say, to try to get medical request. Anthony?
Hello, everybody. I'm doing it right now. Well, I was spending 32 years up there in Louisiana State Prison. It was a time or two I had to make sick call to get some kind of medical treatment, which was supposed to have been medical treatment, which wasn't. First, when you notice a situation developing in you, you would have to fill out a sick call form. You would fill out a sick call form maybe that evening, that night, during the day. And early that morning, EMT, what was supposed to be an EMT, probably took maybe a 10-hour class or a week class or something, and they became certified EMTs now up there. They would come see you, talk to you for a minute, ask you what's going on, and then they say they'll refer you to the hospital to see a doctor. You may not see a doctor till 2-3 weeks later. Whatever the situation was that you was complaining about or making a grievance for, then probably went away now. That's how that process there goes as far as making a sick call. As far as making an emergency, you would have to go to the cabin office or the major office and request to make emergency. They would sign a pass for you and you would walk to the hospital. As opposed to walking all the way to the emergency room, they would sit you in a holding cell. And rather you go into the emergency room, one of them would come see you. Same type of EMT, ask you what's wrong, what's going on. So if it was an emergency, you're not even making it to the emergency room. You're being stopped before you get to the emergency room, being asked questions and interrogated and whatnot. And you may see a doctor that day, maybe a couple of hours later, if that. That's how that process goes for as making an emergency. Now, as far as my personal experience, in 2020, I made 50 years old, and they has what they call an old man physical. When you make 50 years old, when you make 50, you go to the hospital and they do all kind of checks on you. It used to be 40, then they raised to 45, now it's 50. Now, the experience I had, I was somewhat eager to get to 50 to take that test because diabetes run in my family, and I always thought I had symptoms, so I wanted to be checked. But when I was called to the hospital for that old man physical, all they did was a body x-ray and an EKG. It wasn't until a year later they decided to do the blood work. After I asked a couple of times, well, when I'm going to get my blood work done, and when y'all going to finish the old man physical or my physical? And they was like, we're going to get to you, But like I say, a year later they decided to do the blood work, which had to be, I want to say in January of 2021. So by the time they had and did the blood work and sent the blood work on the street down into this hospital in New Orleans, and they sent the blood work back, they detected that my blood level, my PSA had been raised, where I had became a high risk for cancer, for prostate cancer. So from there, they decided to send me to New Orleans for a further check, and the PSA had been raised up higher. It went from a a 8 to a 12. But my thing is, if they would have did the blood work when they were supposed to have did it that year earlier when they first started my old man physical, they probably could have caught it really at the very beginning of it. I probably could have took maybe some pills or some kind of treatment like that, as opposed to waiting a year later to where I had to have a whole organ removed. You know, and that happened once I made it home. But once they detected that my blood level had raised, they sent me back down there to do a biopsy, which was done 2 days before I was released. So when I was released, I come home all kind of sore and everything else. And maybe a week after being home, I started calling Angola to get the results from the biopsy, because they never told me I was cancer positive at that time. So I called a couple of times, they wouldn't give me no answer. They were like, we're gonna call you back, we're gonna call you back. I must have did that for like 2-3 weeks. So then I decided to call the hospital down here where I did the biopsy at. And they were like, yeah, we have you scheduled for a follow-up. So me and my wife went down there for the follow-up, and that's when I found out I had prostate cancer. So their thing was, it done raised up a little bit to the point where the best thing would be to have the whole prostate removed. So that come from them dragging their leg on during the blood work. So that's how that ended. I'm still
Thanks,
recovering now from the procedure, which was done in October of last year, like 6 months after I made it home. Yeah.
Thanks, brother.
Welcome.
And I think sadly what we're going to hear is some more examples that are similar that show kind of more of a pattern there that we're trying to interrupt and stop. And so next I would like to introduce, you're up, right? Oh, Nishi's up. Nishi is an attorney with the Promise of Justice Initiative, and actually one of my favorite people because she's working really hard on this specific issue, and she's going to tell you a little bit more about what's going on.
Hi, everyone. Thank you so much for sharing your story. I'm going to keep my mask on because I've been traveling and, just being cautious. Unfortunately, that's a story that we've heard way too often from clients at Angola and at other prisons and jails throughout Louisiana. I'm part of a team out of PJI, out of the ACLU, out of SPLC, and a couple other organizations that sued Louisiana State Penitentiary back in 2015 over exactly what you just heard, because it happens all too often. Our clients were making repeated sick calls, sometimes 20, 30, 40, over a period of years with the same exact complaints. And all of them were really indicative of either chronic illness or cancer or other serious issues, and they were going unaddressed. And, I think that as a last resort, sometimes attorneys go to federal court. And in this case, we really thought that we needed to bring a lawsuit against the state and against Louisiana State Penitentiary to change what was happening. Unfortunately, we're here in 2022, and litigation takes a really long time. So we went to trial in 2018 for 3 weeks in federal court. We had a lot of really brave clients from Angola speak as to their experiences. And I can't emphasize enough how hard it is to share those types of stories, especially when the doctors and the wardens who are responsible for your care are sitting right across from you. And those clients are just the bravest people for testifying to the court and sharing their stories. The court did find in March of 2021 that the delivery of healthcare at Angola is by and large unconstitutional. Specifically, she found that specialty care, emergency care, clinical care, and infirmary care were areas that really needed to be fixed. In her ruling, she specifically noted that there were overwhelming deficiencies in the medical leadership and administration of healthcare at Angola. So where we are now is that we are entering the remedial phase of the lawsuit. So in June, we'll have a 2-week hearing in front of the judge where we'll try to show her all the ways that we can fix the system. And we really hope that, litigation is tough and it takes a long time, and we're here 7 years later, but that we're going to start to see changes in the system. And I think that along with all the other pieces that Vote and others are doing, what we're doing at the legislature, what we're doing in terms of individual advocacy, is going to make a difference. And so if anyone has questions about the litigation or wants to know more about it, I think, are we going to have a Q&A at the end? Yeah. That's all.
All right, thanks, Nishi. And now we're going to pass the mic yet again to another esteemed colleague of mine. Ashley Wennerstrom is a professor of public health at LSU, and she is an overall superstar in certain realms, particularly around community health workers. And so she has been a part of the team that we've assembled to really interrogate this issue, and she's been working on it for quite some time. So I'll pass over to Ashley.
All right, thanks, Bruce. Again, yeah, I'm Ashley Wennerstrom. It's a pleasure to be here today. So thank you all for having me, and thank you, Anthony, for sharing your story. Unfortunately, it's very similar to a lot of what I've heard in doing research with formerly incarcerated folks about the healthcare experiences that they've had while they've been incarcerated. I'm here today to talk a little bit about House Concurrent Resolution 91, which was passed in 2020, which was basically the Louisiana legislature asking for a report on the adequacy of healthcare in prisons in our state. And I was lucky to have the opportunity to work on that with Professor Armstrong, who you'll hear from in just a minute, as well as Bruce and some other colleagues. So just for a little bit of background for those who might be new to the issue, the Louisiana Department of Public Safety and Corrections is required to provide both medical and mental health care consistent with community standards, so the same thing that we would expect to get out here in the community, to about 16,000 people who are incarcerated in Department of Public Safety and Corrections facilities. So we did this report last year to look at the adequacy of the health care that's provided in these facilities. In order to do that, just a sort of brief overview of our methodology, we reviewed a lot of materials. Those included materials that we requested specifically from DPSC, including handbooks, budgets, contracts, previous audits that had been conducted internally, as well as those done by the American Correctional Association, healthcare policies, descriptions of the programs they offered, and we also reviewed several documents provided by the Louisiana Department of Health related to programs that are offered inside of some of these facilities. We also did some interviews of healthcare professionals who take care of incarcerated people at outside facilities. So we talked to 9 healthcare providers that are working at hospitals or clinics that have contracts to take care of folks for emergency services, and or if people are just unable to get the care they need inside, and sort of ask them about their experiences. So I'm going to highlight a few of the findings from our report, and then I'm going to pass it over to Professor Armstrong to talk a little bit more. So first, I'm just going to talk a little bit about the healthcare needs of people who are incarcerated. First, it's really important to understand that nationwide, we know that people who are incarcerated tend to be much sicker than the general population, so we expect that there are high levels of need for healthcare. Specifically, we usually find that folks who are incarcerated have roughly 3 to 4 times the rate of hypertension, diabetes, and serious mental illness of the general population. These patterns are very much the same here in Louisiana. Just to give a few examples, in fiscal year 2020, about 6,000 people who are incarcerated in DPSC facilities had hypertension, and over 400 had heart disease, about 1,200 had been diagnosed with diabetes, and roughly 1,600 had chronic obstructive pulmonary disorder. So we can see a lot of healthcare needs here. I should have mentioned previously, I just want to add right now, when we were doing this report, what we were looking at is the medical care provided exclusively within the state carceral facilities. I want to be clear that we are not talking about half of the incarcerated population in Louisiana, which is currently housed in local jails. So we did not assess those health conditions at all, or health access to health care in those situations. So I want to highlight just a little bit more a few specific statistics on health conditions that people who are incarcerated are experiencing, just to sort of illustrate how widespread the issue is. At Allen Correctional Center, about half of the men there have been diagnosed with hypertension. At Dixon Correctional Institute, there is an in-house dialysis unit, and about 40% of the incarcerated folks there qualified to receive a medical diet. At Raymond Laborde Correctional Center, 32 medical-related deaths occurred between 2015 and 2019, including the death of a 24-year-old man who died of asthma. At Louisiana Correctional Institute for Women, about half of incarcerated women have a prescription for a mental health condition, and there are approximately 30 pregnancies in a given year. At Louisiana State Penitentiary, also known as Angola, prison doctors ordered specialty consultations over 8,000 times in 12 months, but only completed 50% of those within that time period. I won't go into too many more details on these statistics, but you can see them up there. But just, point being, we've got a lot of folks who have a high level of need for care. Now I'm going to talk just a little bit about sort of the process of accessing healthcare and some of the challenges that come up with that we found. Much of what Anthony described is illustrated in our findings. So one thing to understand is that medical copays are required for folks to access care. It is usually a $3 copay for what's called a sick call visit. This also includes dental visits, $6 for an emergency visit, and $2 for a prescription. Which, if we think about our day-to-day life, might not sound like much money. However, it's important to think about this in the context of wages that people earn when they are incarcerated, which is often roughly in the range of just a couple of cents an hour. So just to give some context, a real-world minimum wage equivalent of these rates for incarcerated people who earn these incentive wages of 2 cents an hour would be almost $1,100 for a routine visit, and almost $2,200 for an emergency visit, and just over $700 for a prescription. So pretty strong numbers there. Also want to highlight a couple more things. Preventive medical care. As Anthony described earlier, he talked about getting the old man visit when he was 50. It's important to understand that the policies that we found only provide for annual wellness exam for those individuals who are over 50 years old. So no routine preventive screening for folks who are under 50. And even with that policy, we see that some folks who are over 50 do not get that care. When we talk to outside physicians who are responsible for treating people who are incarcerated, what we heard over and over again from them is that it's very clear to them that incarcerated folks are not getting the preventive care that they need. And I'll just read one quick quote from someone that we interviewed, a physician that we interviewed, who said age-appropriate cancer screening, talking about age-appropriate cancer screening, said it's one of the most significant preventive service lacking. It's clearly mandated. It's one of the clearest public health guidelines in this country, and that is not happening on a sustainable basis as far as I can tell with people who are incarcerated, which just illustrates the story that we've just heard. Just a couple more things I will mention, as I've been talking for a long time now. Dental care. Policies do not provide for annual preventive exams or cleanings. A sick call visit is the only way to initiate dental care. And just as one example, at Allen Correctional Center, with a population of 800 people, we found that only 142 dental treatment plans were completed within a 12-month period. So pretty low access to dental care. Sick call process. When folks are feeling ill and would like to see a provider, they have to obtain a sick call form to fill out to make their request. Oftentimes, these forms are not freely available, and people must ask for a form from a non-medical staff member. And then in some cases, those forms are submitted to a non-medical staff member rather than some other confidential way, such as a lockbox that could only be accessed by healthcare staff. So that certainly raises issues around confidentiality, and it certainly might inhibit people from being willing to disclose information that could potentially be sensitive, either related to physical or mental health. So those are some concerns. And then finally, I will just mention that we found that people often face or can face potential disciplinary charges when they are asking for care. Oftentimes they are being charged with malingering if the provider does not find that they have the condition that they have that's stated that they have. So certainly risk of disciplinary action like forfeiting good time credit, losing visitation or canteen privileges may inhibit people from requesting health care services. I also do just want to highlight one other thing that Anthony mentioned. He was talking about when he would make a sick call, he was usually seen by an EMT. I have heard that over and over again in research I have done with formerly incarcerated folks, that the process requires that an EMT or an emergency medical technician first evaluate them before they're able to see a healthcare provider, which is concerning because EMTs, as far as I understand, do not have the proper level of training to really make those evaluations. And so with that, I will turn it over to Professor Armstrong, who's going to talk a little bit more about some of the healthcare delivery issues that we found in our report, as well as healthcare administration issues.
Great, everybody. Well, hi, I'm Andrea Armstrong. I am a professor of law at Loyola University, New Orleans, and part of the research team that did the adequacy report, and, working closely with VOTE and their members to really help us understand what healthcare is like behind bars and the ways in which it could be improved, because it is a sacred obligation to hold somebody on behalf of the state. And that means that the government has to honor those constitutional rights and that obligation. So what I'd like to do in my 10 minutes with you is to talk about two additional aspects of the report that we did, and then share a little bit about another research project that I've done, which has been analyzing and collecting, in fact, death records behind bars here in Louisiana. So first, let me start with healthcare delivery. And I don't want to necessarily go through each and every bullet point here because I've only got 10 minutes, but I do want to highlight a couple of things for you. So when we think about healthcare delivery, there's a bunch of different challenges that we saw in our review of the policies, documents, and in the interviews. First, when we think about chronic care, we have a rapidly aging population, right? So those old man physicals that Anthony was talking about, more and more of the population behind bars is going to require those visits. And often they're finding certain conditions that mean you need chronic care, meaning you have to continue to see a medical provider. It's not solved on one visit. But in internal audits, so these are audits that the Department of Public Safety and Corrections did on its own, found that not a single prison that is operated by the state was able to complete 100% of the chronic and specialty care consults that were ordered within a calendar year, within 12 months, I'm sorry. So that means that, let's say Anthony does see a doctor who then issues an order that there should be a outside visit to coordinate and examine the specialty care that he would require. In none of the prisons, not a single one of the 8 was able to complete 100% of those orders within a 12-month period, meaning they had a year to arrange those visits and they failed to do so. Another issue that I'd like to raise on healthcare delivery is thinking about folks who are in restrictive housing settings. Restrictive housing is another term that correctional officials use for solitary confinement. And so when we think about the experience of healthcare, it can be different if you are in general population versus if you're in solitary housing. If you're in solitary housing, the barriers that Anthony helped us understand are even higher to receiving care. So the care that you'll receive in solitary is often delivered cell side, meaning they may not even come into the cell to examine you. It is delivered through the bars of the cell, meaning any of your tier mates can then hear the things that you were talking about in terms of your confidentiality about your medical condition. It becomes hard then, it creates complications for getting prescriptions. So pill call, for example, if you happen to be you have to be standing at the tier front in order to get your pill call distribution. And so if you happen to be still sleeping or you're in the back of your cell, they'll just continue to pass by and you've missed your pill call for the day. It also raises complications in terms of emergencies and treatment. The third category that I wanted to focus on in terms of healthcare delivery is emergency care. And this will come up a little bit, I think, in a later presentation when we think about medical releases. But at least in one prison, there was a policy around 24-hour infirmary housing, meaning that a person is essentially assigned an infirmary bed as their cell assignment. And certainly a question that we need to think about is if someone is assigned to the infirmary for 24-hour care, perhaps the prison is not the best suited place to be providing that care. And instead, there may be other treatment forms that are more appropriate. So switching from healthcare delivery to healthcare administration, this is essentially how the Department of Public Safety and Corrections provides for healthcare delivery across all of the prisons. And here I want to highlight just a few items. The first is the license status. So in the case that Nishi told us about in Lewis versus Kane, one of the stipulations that the Department of Public Safety and Corrections made is they said that at the time of hiring and for the time period concerned in that case, every single doctor had been hired on something called an institutional permit. An institutional permit is basically a license that only allows you to practice in a quote-unquote institutional setting, meaning those doctors, usually through disciplinary consequences, violations of their medical oath of office, their medical oath that they take, that they are only allowed to practice in an institution and they're not allowed to practice in community, right? So doctors that are prohibited from practicing on us out here are allowed to then practice in prison. When we say institutional settings, though, what we really mean is they're only allowed to practice in prisons. Because of the way in which Medicaid and Medicare reimburses, and because Medicare and Medicaid require fully licensed doctors, nursing homes, which would be another institutional setting, can't hire these doctors. And so the only place that they practice is in prisons. Another issue that I'd want to raise, and something that might come up a little bit later as well, is the ongoing vacancies and turnovers in terms of medical care staff. It creates shortages in the ability of healthcare staff to be able to reach people and then to be able to diagnose. Last, the records, although they are moving towards electronic records, we see that most of the records for people who are incarcerated are in fact paper records, which complicates care, complicates coordination of care, especially when we're talking about chronic or specialty care that's needed. So all of these themes that we've been hearing, we also see present in another project that I'm doing, which is about Louisiana deaths behind bars. So my students and I at Loyola collected for the first time in the state a comprehensive list of who had died behind bars. Before this project, that information either wasn't public, it wasn't collected. We had to go to 132 different facilities in order to collect this information. And what we ended up finding was that 786 people had died behind bars during this 5-year period. So the question is, who is dying behind bars? The most impacted, which reflects our disproportionate rates of incarceration here in this state, shows that 11% of the deaths were black men, ages 55 to 60, serving time for convictions. And so this helps you understand that the population that is most in need of care as our prison population ages, and reflecting the disproportionate incarceration of black men in this state. They are 2/3 of our prison population. They are at most 1/3 of our statewide population. Shows that they are also disproportionately impacted by these deaths. On average, they're serving about 12.9 years. When we look at the causes of death, we see that it's primarily medical care and medical illness that they're dying from. and after that, suicide. So here's an overview of the different categories of death. There you see that 87.75% of the deaths are ascribed to medical causes of death. Next slide, please. There we go. And so this is a breakdown of the causes of death by medical illness across the entire population. And similar to statistics that we see in community, we do see that heart disease and cancer are the leading causes of death. At the same time, information and interviews that we did as part of our healthcare study indicate that people who are behind bars, when they are seen by external health providers, are presenting with more advanced stages of the disease at younger ages, right? So more advanced disease, younger ages, and therefore also more deadly. And so even though the causes are similar as in the community, it raises questions about the ability of prison healthcare systems to adequately diagnose an illness and then treat an illness. I'd like to turn to my last slide, which is about pre-existing conditions. So this was, I think, one of the most interesting findings that our project made. In general, 53% of the deaths were not due to a pre-existing condition. More than half were not due to a condition that was identified before their admission to the prison. Well, what does that mean? That means that for 53% of the deaths, the prison-based healthcare system was the sole source for identifying, diagnosing, and treating that disease. Again, because of the sentences that we levy here in the state of Louisiana, which are often extreme and lifelong, it means that folks don't have the option of getting a second opinion. They don't have the option of immediately accessing care when they feel ill. Instead, they are uniquely dependent and, in fact, prohibited from seeking that external care. They are uniquely dependent on the health care that is provided in these prisons, and we see that reflected in these death statistics. So I'd love to share more with anybody if you're interested about our research. We are currently collecting and analyzing deaths in 2020 and 2021 and expect to have some updated information for you towards the middle of the summer. So thank you so much.
Thank you, Andrea. A great vital resource that we have here in the state of Louisiana. Constitutional law professor, very familiar with the Eighth Amendment and what is required, and a lot of hard work going into what we've got here. Next, we're going to turn to a wonderful person who is really brilliant and engaged, Dr. Anjali Nayogi, who's also the director of the FIT Clinic, the Former Incarcerated Transition Clinic, which is a partnership that we formed. And so she's going to tell us a little bit about the another report that came out of the legislature last year around medical releases and paroles, and HCR 51, I believe it was. Is it 51? Go, Anjali.
Cool. Thanks. Thank you for having me here, and thank you, Dr. Armstrong, for that wonderful presentation. And I want to sort of add a little bit to that. So in addition to my role at the FIT Clinic, I'm also a physician at University Medical Center. And University Medical Center is a contract hospital for the Department of Corrections. And so I am taking care of people who are currently incarcerated that the prison is sending over for higher level of care. So I am one of those physicians who is on a near daily basis seeing people who are incarcerated, who are coming in with very late diagnoses of illnesses. And so when I'm speaking to some of my patients who say, I've been complaining of this back pain for 2 years, for 3 years, for 4 years, I wasn't seen, I was told that I was just trying to get out of work duty, etc., and it progressed to the point where I no longer can walk, or I no longer have feeling in my legs. And when they come to us and we finally do the MRI and we find that there is metastatic cancer, that they have cancer that has spread to the body, and so at this point we have to tell them, I'm sorry, we have no treatment to offer you. We can help at best to relieve some of your symptoms, but had we seen you 2, 3, 4 years ago when you first complained of your back pain, perhaps we could have cured your cancer. So that's sort of the background with which I have come into the work specifically around medical release and compassionate release. This has been during my time at UMC and before that, University and Charity Hospital, I've always worked with the Department of Corrections with individual patients to see if we can get an individual released. And I will tell you, it's been a very, very difficult process to do so, and there have been a lot of things that I don't really understand of how that process works. And then when COVID hit, and I think all of us know that COVID hit our correctional facilities and institutions much harder than it hit in the general population. And so our prison population, or incarcerated population, who didn't have an option to isolate, to quarantine, weren't always provided adequate masks, weren't always seen for their symptoms, and have underlying medical problems. I don't know if this was covered, but people who are incarcerated are 2 to 3 times more likely than the general population to have any medical condition. So diabetes, heart disease, high blood pressure, all of those risk factors that we know increased your risk of death from COVID is what our population in prison has, higher than the general population. So when COVID hit, we were seeing people coming in with COVID from the prisons, and we said, hey, can we at least temporarily, while this pandemic is happening, release some of these people so that they're in a safer place, so that they don't have to suffer undue consequences because they have no other options of isolating or quarantining. And so we submitted maybe 2, I can't remember the exact number, but hundreds of around 100 requests. And I will tell you that 0 of those requests were answered, much less people were released. So not one. And so then that led us to really look at, why do we have such low rates of compassionate release? I think we learned during that time in all of COVID, March of the year 2020, when COVID was at its highest, Louisiana released 7 people within the state under compassionate release or medical parole, 7 in the entire state in a year. And so that led us to why? Why are we so low? Other states were releasing people, federal prisons were releasing people, not in the numbers that we needed, but certainly more than what Louisiana was doing. And so that led to House Study 51, which involved promise of justice, multiple community physicians, family and friends of formerly incarcerated individuals, victim advocates, the Department of Corrections, Louisiana Department of Health, Medicaid. It was a large group of people that came together to really look at how does compassionate release, medical parole, medical release, medical treatment furlough in Louisiana work. And one of the things that I think that stood out to me the most was that we just don't refer enough people to be released. So we have a low number of people that are getting out, but there's also not a lot of people that are coming up to get out. And so that was one of the biggest things that we saw, is that our numbers are just really low. One of the other things that we found was that there's a lot of confusing verbiage around what all of these things mean. So we have in Louisiana, we have compassionate release that says you must die within the next 60 days. We have medical parole, and then we have medical treatment furlough, which says we'll let you out for a short period of time to go to a nursing home and get some care, and we'll bring you back. But the verbiage and the way that these things are worded were very confusing. They were confusing to me, and I work in this field, and I couldn't quite understand what the differences were, but they were confusing to the entire study group that was looking at all of this. Some of the other things that we found were very restrictive. As a physician, looking at things like you must die within the next 30 to 60 days, I have no ability to predict when someone will actually have their end of life moment, when they will pass on to the next stage. I don't think that there is any physician that is capable of telling you when that happens. And so we really, some of the things that came out with that study was that we really need to redefine and rethink the way that we're talking about what it means to get people out. Remember, when you're incarcerated, I'm sure that probably all of us have had someone who's a loved one when someone is ill and, is particularly if they're facing terminal illnesses or illnesses that may not have immediate solutions, we want them to be around friends and family. We see that people get better, or at least live longer, live happier in whatever time they have left. And so that's really what we are advocating for from physicians and from the healthcare standpoint. We are not saying, we want people to be out who may be able to go and, be back into the communities in any way. We're just saying we want people who are sick to be able to get the help, the care, and the love and the support that they need. So that was sort of our impetus for this. So I told you the study results, and then for this session, we submitted a legislative bill. Numbers escaping me right now. Thank you. 728, which specifically looks at a few things. One is that we want to change the verbiage. We want it to be more user-friendly to say, how do we look at compassionate release, medical release? Can we eliminate things like furlough? The other thing that we want to do is we want to increase the number of people that are referred for these things. And so right now, I think we had 128 or 138 that were referred over several years. We want to increase that number. Everyone who is eligible for release should be evaluated and screened for the potential of release. And so what are ways in which we can do that? One is changing the terminology, but the other is also utilizing physicians in the community, such as myself and other physicians who work at contract hospitals for the DOC, to have a way in which they can also make recommendations for release and evaluation and screening. I'm sorry, I'm blanking. My head is elsewhere. We also wanted to change some of the definitions, and so rather than utilizing something like a terminal illness or death in the next 60 days, we thought what we were really talking about are illnesses that are irreversible, but also what is a person capable of doing? So in my field, we use something called ADLs, or the activities of daily life. That is, what are you able to do when you get up in the morning? Can you brush your teeth on your own? Can you take a bath? Can you go to the bathroom? Can you make food for yourself? Can you walk unassisted? And those are really the things that determine how well you are able to, what your recovery will look like. And so we requested in this legislative bill to add some of that language into it, to say, let's flip it from just being about death in 60 days to what kind of assistance do you need? And so that we can expand and broaden the people who really are not served well in the prisons and would benefit from care outside of the prison, wherever that may be. We also, one of the things that we learned was that the whole process, once somebody is even referred for medical release or compassionate release, what happens after that, no one really knows. Even when I make a recommendation from University Medical Center, it goes into some opaque system, and I have no idea how to follow up on that. But we also realize that the people who have been recommended, the patients themselves, also have no idea. Their friends and family have no idea. Their attorneys have no idea. No one really knows what happens. There was no time frame in which they could expect to have an answer. Again, think about this. You're really sick. This is potentially terminal illness, and You just don't know what's going to happen the next day, next week, next month. And so one of the things that we requested was that there be some set timelines and some time frames in which, once that request has been made, everyone is alerted to what the next process would be. When can they expect to have an answer? We've got to make plans, right, with our families and all of this. We also wanted to have the process be more transparent to all of the community. So we wanted to have referrals be able to come in, not just from community physicians, but from family members and other people. And so we requested that there be a handbook of some sort that would be created and shared with the patients, with people who are incarcerated, with their friends, their families, their attorneys, so that everyone knows what this process looks like. How do you make a referral? What can you expect once that referral is made? Who will look at that referral? We did advocate for it to be prison physicians, but also community physicians who take care of patients who are incarcerated, who have high chronic needs. And then once a decision has been made, what are the next steps? Do you have the ability to appeal that decision or not? Currently, all of the medical releases, regardless of what they are, go through the standard parole board, as we have now. And so we've requested, maybe everyone who's on that parole board doesn't understand the nuances of, chronic diseases, illnesses, long-term illnesses. And so can we do additional education with that parole board? That's about.
We're a little low on batteries here, so always seeking donations. So everything that we've spoken about and everything that's been shared, is kind of like what goes into the way we think about creating change. And so, between the Lewis v. Kane lawsuit, we learned a lot. The three reports that were referenced, we learned a lot. And then, of course, as Anthony's story attests, we learn a lot just through our own direct experience. So, we went into this session with the team trying to figure out what is it that we can do that's, in a way, going to help everybody, right? We're not trying to get over on anything. And we also know that the lawsuit actually is going to come to a head, and the courts are going to order the state to do something. So we tried to be a little bit proactive, and also just elevate this conversation. So one of the bills that we also introduced this year through Representative Larry Selders out of Baton Rouge is HB 517, and that is about pretty much creating a medical advisory council. Because we've learned that, as it's been mentioned, that too many of the medical decisions kind of fall within the correctional umbrella, right? So it's like a security system making too many medical decisions. And we also realize that maybe they're not hiring the right people, and it sounds like they're struggling to hire people. So we figured, if we put the medical field in charge of this realm, which we feel they should be, it's their profession. Lawyers don't become immune from lawyerly oversight just because they're operating in prisons. Wherever you're practicing medicine, you should be underneath medical professionals. And so the Medical Advisory Council, we kind of pinched from some usual suspects lists, and thanks to people like Dr. Niyogi helping to figure out like what sort of specialties should be listed in the advisory council. But it's not a bunch of community folks, it's a bunch of medical folks, and their job is basically comes down to about 4 different things. One would be around the hiring of the corrections statewide medical director, and we feel that if you're going to hire someone to basically oversee a large series of clinics, they probably need a certain level of skill and expertise, and their pay should reflect that. So we feel like that should be just a given. Secondly, they're going to, advise and consent on all the different healthcare policies, some of which we've already mentioned. Others are a little bit more detailed, including in, how long is that ruling in Louis v. Kane? Like about 120 pages or something? 124. Maybe I skipped 4 pages. But, it's really good reading for those that really want to understand, some of the sort of legal problems with it. I mean, some of it's a little bit dense, but a lot of it is really I think easy to read, maybe hard to read in a humanitarian sense, but easy to follow what's wrong. So we know that some of these policies need to change. The DOC has admitted that some of these policies need to change. So why not have medical people giving their, weighing in on what those policies might be? Third, going to Dr. Armstrong's report around deaths behind bars, they don't do post-mortem reviews, which, correct me if I'm wrong, Dr. Niogi, but every hospital, if someone dies under your care, it's pretty standard that you would review what happened so you don't make the same mistake twice. They don't do that. And why? That's, someone else can answer that question. But we also know that they're just not learning from the experience of what's happening. And that should just be, it should be unheard of. And then finally, they should help implement an electronic record system. Who better to, advise and consent and sort of order and design, define, whichever, the medical system other than people who run, Ochsner and LSU and Department of Health and all the other kinds of stuff. And so they would be able to pick out, one of the systems and just implement it, because as we've heard, it's really hard to keep up with people's appointments and what's happening and everything that happened to Anthony and all the other folks around Vote, because sadly everyone has a terrible medical story, and it's either personal or it's personal because it's someone super close to you. And I have many myself. So, we wanted to get that, the HB 517 in law. It also reminds the state what is already a law. But the DOC, if you went to go get a job at the DOC right now and went on their website, you would see that you can't work there where you have a felony conviction. It doesn't say in the last 6 months or last 6 years, last 6 lifetimes. It just says a felony conviction. And so, as we've heard through various ways, and there's journalism out there, so many of the doctors, if not all, have a felony conviction, including the current state medical director who had a conviction for distribution of meth, or a possession with attempt to distribute meth, and served time in federal prison on it, not that long ago. I mean, he did time after I got out. And I face discriminations all the time, and yet here he is in a trusted position over all these doctors who are over all these people behind bars in terms of getting medical care. So they're violating that on a regular basis. I'm not sure exactly how, but they do it. But as many of us know, those who make the rules often break the rules. A couple of interesting conversations for people to tune into around some of these issues on our podcast, From Change to Change. If you're not tired of my voice, I get to DJ Bruja that and co-host with Norris, and we've got Royce Duplessis, who is the sponsor of the medical release bill, and he talks in about parole and just a lot of these issues generally. And then also Representative Mandy Landry, who's the sponsor of HB 175, which is about the copay. And that bill actually got heard today, this morning, as we speak. And right now, our amazing team has always in conversation with the Department of Corrections. We've got a little frenemy thing going on. They respect us. We know they have a hard job, and we're trying to actually make it easier for them. And we're hoping they just kind of went to the desk today and said, "Look, there's too many sick people, and there's not enough doctors. There's not enough money. Help us." They didn't say that. It's this kind of we've got it under control type attitude, which is not helping anybody. So the ship is sinking, and you really got to be able to identify what's wrong with the ship. And they don't have enough money to do it, and to have a copay in place as a sort of deterrent so that you don't have as many request slips, which is interesting because during the case they said there's no evidence that it serves as a deterrent. But now they're basically saying we need it because we need the deterrent because we can't handle all of the request slips that'll come in. So I'm sure they're kind of, being careful with their words and maybe not careful enough, but that's not our issue, that's their issue. So we're hoping to get that changed a little bit. Mandy Landry did get a fiscal note behind that bill, which the DOC reported that they made about $167,000 in fees average. Now, it may sound like a lot of money to you and me, right? But in the course of $1 billion budget, it's pennies. The medical budget alone is $100 million. And basically, if you do the math on $3 fees, it's somewhere around 55,000 transactions at $3 a whack. And so you can only imagine how many hours and time and energy goes into collecting the 167. And for someone to make a mention that maybe we can amend it down to $2, well, that actually just makes it even worse, because now you're actually probably spending more money than you're even collecting. It's not even a break even. So we're trying to work that out and actually figure out something that they can live with. I'm sure they know that the medical fees issue is a problem. We don't like to call it a copay because that kind of legitimizes it. I've got a copay, you got a copay, you got a copay. This is a fee. It's not a copay, right? They don't have insurance in there. And they're not like choosing between this provider and that provider, right? This is a constitutionally mandated 8th Amendment thing. You either got to treat people or release them. And so we're coming up with a comprehensive way of folks being treated or released, right? We have the medical release program. And so those of you who have made it this far are probably wondering, like, well, what can I do? Glad you asked. Because here at Vote, we're all about what can we do. And part of one of the things we do is we educate ourselves and we build ourselves up so that we know how to talk about these issues. And if someone throws you like a little zinger, you're able to say, oh, well, I know a little bit more about that thing, and I'm going to come back on your zinger. Like, what about the $167,000? And you come back and say, what about the $180,000 to collect it, right? So, but one of the biggest things that we do is we contact our own legislators. And one way that you can find your legislators, there's many ways, but one way is a website called openstates.org, and then it's Find Your Legislator. If you just Google it or type it in, you will find it. Let your legislator know where you are on these 3 bills and others, whatever comes to mind, because obviously building a relationship with your representative is part of the process. Some of these legislators may be the all the way on board ones, but they also, I think need to hear how many of their constituents are impacted by these things. And some of your legislators, they may not be the so-called usual suspects or good guys or civil rights champions. And so it's really important to let them know that every district in this state is impacted by the healthcare and the prison systems in the same way that the unanimous jury issue, when we went to a statewide ballot on it, it won in 61 out of 64 parishes. So the idea that this is just a New Orleans thing or just a Baton Rouge thing or just a anything thing, it's all of our thing, and it's really important for us to spread that around. Another thing you can do is the ACJ committee is where all of our stuff is coming through. And one might argue it's a shame that it's not in health and welfare, because we're really talking about healthcare. And the very fact that you can take healthcare when it applies to a certain group of people and just turn it into a prison issue, just a criminal justice issue, right? Like, are we coddling criminals, so to speak, by giving them testing for cancer? And that's the way some people are thinking about this issue. And we got to reframe it. This is a healthcare issue, but we don't control where a bill goes. So we've got the ACJ committee right here, and we're all y'all can contact us at any time, and I'll get into that in a second. But giving them calls, giving them emails, being polite and firm is the best way. Tell them what you're for. You don't have to always tell them what you're against, but sometimes you got to do both. Our little list here that we provided, gives you kind of like the main city of where they're from, so people understand Marcus Bryant, Lafayette, Jonathan Goudeau, Lafayette. Or if you come down this way, you got Garofalo and Chalmette, Villios and Kenner, Joe Marino's and Gretna, right? So they're all around this area, and reaching out to people is a really important thing. Another thing that we can do is we can create a buzz. That's something that we do, is each one teach one. We educate, we mobilize, and so when we're using our social medias, we share things. People that are watching this right now on a live feed, whether it be Facebook or on the YouTube, I'm 99.5% sure it'll be there after the fact. You can share that as well, and any articles that come up, studies, reports, things of that nature. Andrea, what is the website for your? Incarcerationtransparency.org is Professor Andrea Armstrong and her team's website for the deaths in custody, because really what we want to know is what's going on. It is about transparency. And then, you know, another big, huge thing is obviously come testify or stand in solidarity. For those of you that are medical professionals, it's really important. You know, one of the things that we're trying to do is spread the word into this profession. When we speak at med schools, for example, you know, people are just like, oh, I had no idea. And we know you don't have any idea, but we're here to try to tell you. And so we all have to each one teach one. People can go to our website, www.vote-nola.org. And if you go to the legislative corner, you'll see our bill tracker, and that'll tell you like when a bill has been scheduled for a hearing. And so, and if you jump onto our social medias, our newsletter, we'll definitely let people know when these bills come up. And for those that would like to testify on this issue, it's great to, you know, talk with us, because we've done testimonies. We can kind of go over like what are some great bullet points to hit. Maybe we're trying to cover different areas, and you're going to tell this story about that. You're going to tell this story about that. Because in the end, you know, we got to educate, organize, and mobilize. And that's what we do here at Vote. And I'm really thankful and grateful for you guys to join us. But I know we talked about a whole lot of stuff, and any of us can try to get a little bit of clarification, I think. If you have a question, someone else might have the same question. So feel free to pose any in the time we have remaining. Anyone? It's funny, I had one for you earlier and I forgot what it was. I don't remember. Okay, well, tune in for more. Stay up to date, and thanks so much for joining us. Ciao, ciao.